in part of STOPS pretty much since its inception. So STOPS isn't new to me. So thanks for joining us today. I was asked by STOPS to provide some information on an initiative here in Saskatchewan called social prescribing. And that's what I want to provide is some information about it, basically what it is, where Saskatchewan is with respect to social prescribing and what's happening right now in the province. Um, it is new. Everybody's learning here in the province about it. But as we go through this next 40, 45 minutes about it, there may be questions, and we'll take those at the end if that's okay. At some point through the presentation, I'll be asking Nofa to put in the chat some links to various other information that you may be interested in related to social prescribing, and only within the province, but also across the country and other topics as well. So to get going, what I want to talk to you about today is social prescribing, and you can see there the tagline, living well in your community. The "your" being highlighted because this initiative is about working with the individual. It's their community, not ours, because so often people are being told, oh, you need to do this, you need to do this, you need to do this. Well, what happens when we turn the table and say, what would you like to do in the community to ensure you have some form of healthy lifestyle as well as living with well-being? So the tagline fits very well. And again, it's about community. And I'll get into that as we move forward. You'll also see we've developed a bit of a logo there in the top right-hand corner. You may wonder why that's drawn like that. Well, the whole idea is when you see the person there in front of the house, we're hoping that people can live as long as they possibly can, if they choose to do so, in their own home. You know, we all know that sometimes health doesn't allow us to do that, but majority of people, if they choose to, would like to. The other one there is somebody's got their arm over the shoulder of somebody else. It's talking about connection, working with people to assist people. You got another graphic there with somebody with weights. I'm not saying everybody needs to go out and get new weights and start doing weight training, but the whole idea is having a healthy lifestyle. And in the middle there, you've got the taxi cab. Transportation is an issue. But at the bottom there, we still have to address the issue of people do require medication sometimes, but what happens when medication isn't the be all and end all, and there's some social issues driving them to have to take medication? So again, I want to talk about that. So that's why we developed that logo with the support of other people in the field. I do work for Saskatchewan Seniors Mechanism. I am the provincial social prescribing coordinator, and I'll explain how I got that position. So, social prescribing. Social prescribing is a means for physicians, healthcare workers to connect patients to a range of non-clinical services in the community to improve health and well-being. And its social prescribing can help to address the underlying causes of patients' health and well-being issues as opposed to simply treating the symptoms. We've all, at some point in our life, gone on to see the doc because we hope we'll get something to address something we think is medical. However, sometimes they may need to give some prescription for something, but the folks in the medical profession may not have the time to ask what is driving these individuals to come and see me to get medication for, say, depression, anxiety, and things like that. It could, in fact, be that something else has gone on from a social point of view. Just to give a quick example, during COVID, it was brought forward, and I think everybody knows this, that social isolation was a big issue. And it really identified that was something that needed to be addressed. So imagine I lose my partner a year and a half ago, and my partner was the the social butterfly, the person that knew everybody in my community, arranged everything and that, and then she passed away. Now I don't have any connection with those folks. I don't know what's going on in the community. And slowly but surely, I've started to go inward and become depressed and anxious. And I go and see the doc, and maybe the doc or the public health nurse provides me with medication to address that need. However, what happens if that issue of loneliness and social isolation and connectedness is addressed? Do I really need that medication or as much of that medication? So the whole idea is to have folks in the medical field, the physicians, the primary health care nurses, home care and other health professionals, to do their role, but to have an opportunity, an option to actually have somebody work on the social aspects of it. So it would promote community-based integrated care and helps to reduce some of the dependence on health service provisions. Just to give you an idea about some of the things that might drive this need to keep going to see the medical field. What about sometimes community and social context can drive the need for some health concerns to be addressed. When we talk about community and social context, I may live in a community but know nobody in the community or nothing about the community, and it may be a community that has a lot of stuff, but I'm not part of it. So that can drive some of the issues. Healthcare access. Now, we know this is an issue. Everybody's trying to find doctors and things like that. But I was asked early on in this initiative to go and speak to the folks in Allen and Kenniston, to the seniors organization there. And the thing that they brought up was, yes, we can get to a doctor. Yes, we can get to the hospital. But what about here in our own community? We don't have some of those services. Plus, it's not easy in the middle of winter when it's -40 and the roads are closed to be able to get into Saskatoon or wherever they have to go for those medical appointments. So healthcare access can drive some of the issues people have. Economic stability. There may be people who up until a point were okay, and then all of a sudden they may be on fixed income. The rent's gone up in the place they live. And now it becomes a pressure on them. It starts to worry them. They start to get anxious. That's a social issue, but it's driving them to have to, main driving to have to go and see the medical profession to address their anxiety and depression. Identity, do they fit in the community? Language education and literacy. Some of you have seen the forms that are about today from all agencies, not just health, but everywhere else. Sometimes the language of those documents are either so academic or so technical that people don't really know what's in those documents. So again, looking to ensure that people understand what pieces of paper they're given and what it actually says. Some of those things can cause people to worry about, yeah, they told me to do this, but I don't know what it means. Then you've got the physical environment. Yes, Sally or Johnny have lived in a community for 60, 70, 80 years, and now they have their own home, but that home was built at the time when there was no code regarding the angle of the stairs down into the basement or steps going up to the back door and things like that. And now Sally or Johnny are tripping or falling and ending up in hospital because of the physical environment they've got. It's not there's anything wrong with the place, it's just some adjustments may need to be made. So again, that can drive some of the issues. Physical health, at some point in our life, all of us need to ensure our physical health is addressed. We get older, but we can still keep relatively healthy by doing different things. So sometimes if we do have a mobility issue or we're not able to get to a facility where we're able to ensure our physical health is getting better, that might drive some of the issues of having to end up going to see somebody in the emergency room or the clinic or the doctor's office. And then employment and working conditions. And I've said to people over the years, folks, 65 is not an expiry date. That's just one of those things when you can retire. There are still people working into the 70s and 80s because they want to, they enjoy doing it. Some do it because they want to make a few extra pennies to be able to do extra things over and above what they already do in their latter part of their life. And that goes back to the economic stability. Maybe somebody, an older adult, has been working somewhere part-time, has getting a few extra dollars to do other things, and all of a sudden that organization falls, and now you got that individual trying to figure out how they're going to do what they need to do when they don't have that money. So again, it can all impact on the individual and community's health. All these social determinants of health are things that drive it. Just to give you a bit of an overview of social prescribing, big picture. In this initiative we have here in Saskatchewan, it tends to basically be driven by the healthcare providers. The reason for that being is that we had to start somewhere, and a lot of the folks, and we're working with a cohort of older adults, 55 plus, tend to at some point go and see somebody within the healthcare profession. And it's at that point where, if there are some of those social determinants that are causing some of the issues for them turning up in the emergency rooms or the doctor's offices, it could be addressed. But you know as well as I do that there are people in the profession that don't have the time. They're busy with it. There's pressure on the health system. But it's an opportunity at that point where they could be doing a needs assessment, doing community referrals, and doing connection out to other supports. Wouldn't it be great if there was somebody or some process there where the people in the medical profession could refer that individual they're seeing before them to somebody else to look at the social things within their community? And that's where it goes into that social and community services part. And I'll get into how it's working here in Saskatchewan. But that's basically the idea of social prescribing. It can be used to refer patients to a variety of activities and services. And Betty Ann, you probably are aware of this. When we developed the domestic violence court in Saskatoon, before it kicked off, one of the judges there had said to folks in the community in Saskatoon, can you identify for me the services and options that are available for victims, for the children, and also for the offenders before we kick off the court? And somebody went away and pulled together a 3-page document of services and programs that were available for everybody. And there were people who'd been working in the field for many years in Saskatoon, didn't even know half the services and programs were available in the community. So again, we may have those things, but the people at the front line may not be aware of all those services. So that's again another thing that social prescribing can assist with. Exact social prescriptions are specific to each community and care setting, but typically they include services providing support in mental health, social inclusion, practical home supports, financial and housing advice, as well as activities promoting physical activity and creative self-expression. There's a lot of stuff in what social prescriptions could be, and this model can be used in just about any area. A year ago, in November of 2023, I have to remember what year we're in now, I was in London and went to a place called Bromley by Bow, and they do have a website. It's a suburb within the City of London, like Walsh Acres in Regina, or Sutherland in Saskatoon, all those areas of the city. Well, that's what Bromley by Bow was. And there was a doctor there, Dr. Sam, who decided that he kept seeing a lot of people coming to his practice, but they weren't, yes, they had some issues, but a lot of it was driven by stuff that was social in nature. And if those things were addressed, they may be able to reduce the amount of times they're coming to see him, as well as the medication. There are those type of things. I know people do get sick from other things that can't always be cured. We know that. But in Bromley by Bow, they've been going since about the mid-90s. They have a number of community or link workers that are working there, that work on various issues, not only the health side, but things like homelessness, addictions, youth, type 2 diabetes, a whole bunch of stuff with different people working on it, but through community. And what they found was there was a reduction in the amount of times people, if by working with the people and using some of the programs and services that could be available, they were finding that people weren't going to the emergency rooms or to the doctor's practices or calling for an ambulance as often as they had been in the past. And so again, it can be used that way. But here in Saskatchewan, right now, we're looking at older adults, 55 plus, and the medical profession as it stands right now. And I'll get into that in a moment. But no one agency in the province or anywhere else can address this issue. As you can see, from our point of view in social prescribing within the seniors mechanism, we also work with age-friendly Saskatchewan, and there are communities here in Saskatchewan that are age-friendly communities, as well as home supports, not home care, but home supports, and another program called Facilitating Independence. We're all part of a jigsaw puzzle, and that's the same with the community. We're all in it together in that specific community. It isn't a case of, oh, well, we've got this program, it's mine, and nobody else needs to know about it. No, it's about working together. We hear people talking about, oh, we collaborate. Well, they talk about collaborating, but they don't actually necessarily collaborate. The whole idea of social prescribing is to build that collaboration so people in their own communities are working together to make it not only better for the individual, but better for the community. In the most common model, physicians, primary healthcare providers, and frontline support staff can refer patients to specialized community connectors who work with clients to identify their social needs. The name that was given, we did a lot of thinking about it. And when I met with Dr. Sam in London, he liked community connectors. He said, because this is about the community. In Britain, they talk about link workers. In other parts of the world, they talk about navigators. But to talk about a community connector, connecting back to the community, he said, speaks to what this really is about, working from the ground up, not trying to push it down. You have to see this Dr. Sam. Dr. Sam stands about 5'7". When I first saw him, his shirt sleeves were rolled up. One of the tails was out the front of his trousers hanging down. Tails of his shirt were hanging down over his trousers. And you're going, who the heck is this guy? But when you listen, you got it. He was a gentleman that said, the clean police hate me because I've got a doctor's office where I've got plants in my office. I don't have, and paintings. I don't have white, pristine, chemically cleaned services. I'm the patient's part of my community, and the patient sat beside them, and those type of things. He decided there's a need to make the patient part of the process rather than I'm here to tell you what to do. So he really is interesting. These community connectors typically work with the clients to co-design personalized plans to improve their well-being and routinely follow up with clients to monitor their progress. And I'll get into how that works here in Saskatchewan. Social prescribing is not an intervention by itself, but rather a pathway that helps to address the individual's needs. The community model can be adapted for each unique context, as I mentioned before. The idea is not to go in and talk to an individual and say, you need. It's with the connectors we have, the connector to go in and say, hi, Sally. Hi, Johnny. Yeah, I've got a referral, as you know, to come and chat with you. Tell me what's going on. What's your story? And drawing from participation of the client with the connector to find out what the needs of the client are. And they're always going to be different. Now, this graphic here, I didn't design this graphic. This is a World Health Organization graphic. And when you look up at the left-hand side, I wouldn't be drawing a graphic of an older person looking like that with a walking stick, white hair, glasses. I mean, that's just not the way we describe older adults. But it just quickly gives you an idea of what we're talking about when we talk about social prescribing. The person would go and see a primary healthcare provider. the provider would assess the patient's need for social prescribing and then refer the patient to a community connector. The role of the connector then is to connect with that individual, that patient, to develop a personalized wellness plan. That personalized wellness plan could be connecting them with something they've enjoyed many years ago but forgotten either how to do it or don't know who's doing it in the community anymore. And the connectors developing maybe a plan around, okay, let's get you connected again. And that could be it. As simple as that. It could be more extensive, but it can be very simple as well. The community connector can refer the patient to an appropriate community-based service, not just here's a telephone number, go. It could be, in some cases, at the first time, making that first introduction with that client to the service or the program that may be in the community they didn't know about. And to also counsel the patient using behavior change techniques. And counsels is not counseling. Counsels is providing information about things to do and possibly change the behavior they've had. And then that community connector will work with the community and voluntary sector to include the individual in group activities as well as services that maybe they're in the community. And then they, as time goes on, they would provide feedback to the folks who made the referral in the first place as to what's been happening with Sally or Johnny. And half the time, the doctor or the primary healthcare folks may already know, because I know when I go and see the doctor to get my prescriptions refilled, the first thing he says to me is, "Hi, Rod, how's it been going the last 3 months? How are you doing?" And most of us will say, "Oh, well, I'm doing this, I'm doing that." We tell that story. So if I'm getting better, I can say, "Hey, I don't have the time anymore to get bored and depressed because I'm out just about every other night now because of what's happened." So again, it's trying to complete that circle. Just so you know what's going on around the world before we get into Saskatchewan, social prescribing as we know it was first developed in the United Kingdom as early as the 1990s through small pockets of practice. By 2016, the number of United Kingdom social prescribing pilot initiatives was growing and prompted development of the International Social Prescribing Network. That's who I was working with in London. Today, the National Health Service, which is like our federal health in the United Kingdom, has incorporated social prescribing into its national model of personalised care. They fund social prescribing in the National Health Service in Britain. The National Health Service itself provides that money. The government provides that money to do this because they, after doing data gathering and evaluations, they realized that by doing this, looking at the preventative side of stuff, the social things were addressed. There was less pressure on doctors' offices, emergency rooms, ambulance transportations, less falls by seniors. There was a whole bunch of things that were achieved over a period of time because of social prescribing. I could go on and on about what's going on in Britain because it really is interesting. But if you search Bromley by Bow, you will certainly get a picture of what they're doing there. Around the world, it's been implemented in 17 other countries. Similar to models of connecting people to the non-medical care have existed, though not united under the term social prescribing. I think it's like anything else. Over the years, we may have called it this 20 years ago, and now we're calling it this today. Those types of things, but we were still doing something similar to it. Those countries, as you can see in this shot, in the areas in red, those are the countries currently that are using and have been using social prescribing as a support to the health services as well as to other areas that people need assistance in. I was in Toronto in November last year and met with a number of the doctors from Singapore, from Australia, New Zealand, and UK to speak about how things are moving there and try to learn from each other. So we're new at it, but it's been going on for a few years around the world. Here in Canada, we are working with the Canadian Institute for Social Prescribing. It's a leg of the Canadian Red Cross. And Sonia is the director. Sonia, I don't know where she gets the energy from, but she does. But the whole idea is for the Institute to act as a national hub to link people and share practices across the country. They're committed to building and celebrating social prescribing that prioritizes health equity, community leadership, and collaboration. So that's at a national level. You might ask, well, what's going on elsewhere in Canada? In this shot, you can see across the country, pretty much all provinces and not quite all the territories, we have people or agencies working on social prescribing. As you can see, in the middle of Saskatchewan, we've got Holly Schick from Saskatchewan Seniors Mechanism. So these people are basically the main contacts across the country, but they're not all doing the same model. In Manitoba, Connie, their social prescribing process is driven out of the seniors' residencies, which is fine because it's still trying to address the needs of those individuals. But what they're realizing is the missing the folks out in the community who may not have gone to a residence, are still living in their own homes, and they're not necessarily getting the services, the services, not social services, but the services that are social in nature that they could get. So Manitoba's looking differently at it. The people we're working with quite a bit is Alberta. They've been around for about 5, maybe 6 years now. They're through United Way Alberta. The reason we're working with them, their demographics are somewhat similar to ours. They have 2 major centres. They have northern and rural communities with various demographics and different cultures like ourselves. The population is different, we know that, but why reinvent some of the wheel? So we've adapted some of the things that they have to become a Saskatchewan model. But there are a number of people across the country working on this. So what is social prescribing in Saskatchewan? Our aim with Saskatchewan Seniors Mechanism was to ensure that older adults 55 plus can live and thrive in their own homes and communities with access to activities, supports, and services they need in their own communities. How are we doing this? Well, first of all, it was there to address social determinants of health and well-being, including safety, security, quality of life, and ability to choose and how and where to live. Not as telling people where to live, but the individual, if they're able, to choose how and where they want to live. And at some point, the initiative will prove the need for investment in social prescribing throughout Saskatchewan. How are we doing all this? This initiative was funded by an anonymous foundation or anonymous trust with funding for a 4-year initiative. We have just under 3 years left in the initiative. The organization that provided the funding is, as I say, anonymous. They even if you were to know who they were, they don't accept unsolicited proposals. It was a foundation, a trust that was developed on the direction of somebody's will, with a lot of money to specifically address these types of concerns with older adults 55 plus. So this time in Saskatchewan, that's what the funding is for. If there's other folks down the road and later on who want to support in other areas, the funding would probably have to come from somewhere else. But right now, that's why we're working on older adults 55 plus at the moment. Who helps us? We've been partnered right from the beginning in this initiative, even before the Saskatchewan Seniors Mechanism obtained the funding. And Saskatchewan Seniors Mechanism didn't go looking for it. The trust, the anonymous trust, came to the Seniors Mechanism that said, we need you to apply for this funding. So SSM, together with the Health Quality Council of Saskatchewan, worked on the proposal to that trust. They have the SHQ. They have responsibility for the development of collecting all the data and the evaluations, because at some point, folks, at the end of the 4-year funding, somebody's going to say, okay, the funding's finished, now what? And we don't want to be at that point. So we working with HQC, I should say, to part way through this process, have that some of that data and do some initial evaluations to be able to provide that to government to show that this works, that it can reduce some of the pressure on the health system. And we have been working, and we were approached by the Ministry of Health to keep them in the loop. They call us about every 3 weeks to find out what's going on in what communities and how it's working. So there is a lot of interest on this primary healthcare, especially within communities. They also are helping us with some communication initiatives as well as other facets of the initiative work through the connection to the medical system. They are well connected within the medical system. So for here in Saskatchewan, this initiative will initiate social prescribing in 14 communities over 4 years. Who picked that? That was based on demographics, population. We didn't just want it in the 2 major centers. We had to look at the whole province with the different demographics. The aim of the initiative is to demonstrate that social prescribing is an effective means to address needs of older adults 55 plus, particularly those who are or may be high users of healthcare. So where will they be? Well, 12 of those communities will be urban and rural communities throughout the province, from north to south, east to west. The others are 2 areas within large urban centres. Now, you know what those urban centres are, folks. It's Regina and Saskatoon, but it's not the whole of Regina and the whole of Saskatoon. It can't be. There's no capacity there for that with the funding that's available. So I know I was working with Saskatoon over the last 12 months because they've been asking about social prescribing. I met with SCOA, Saskatoon Council on Aging, as well as some of the community care workers there. And I asked the question, if there was an initiative like this in Saskatoon, where might it best be placed to address the needs of older adults 55 plus? And they all said, pretty much, well, everybody said, Market Mall. Market Mall is an area where seniors gather, not only for the shopping, but the services are there. There are a lot of seniors' residences and condos and things around that area. But everybody said that's probably where it most likely could start. Would it end up being the whole of Saskatoon? That in the future, who knows? But if it works in one area, why can't it work in the rest? So that's the whole idea of this. So, geez, sorry. This is just going back to similar to what that World Health Organization diagram was. But basically, here in Saskatchewan, we have an older adult who goes to see somebody in the primary healthcare system, be it the family physician, the nurse practitioner, the emergency room nurse, the home care. And we're even talking right now, because of identifying some of the things, it could in fact be the pharmacist, because pharmacists have been provided with extra ways to address some of the needs of patients that don't necessarily need to go to the emergency room. And sometimes we have to consider possibly firefighters and police officers who may get a call at 2 o'clock in the morning to go and, because somebody's fallen or something like that, they attend out. The story may be different every time, but they may be somebody who can make that referral. But we're working on that. But the community connector would get the referral, and then they would connect with the patient, and at the same time identify through a local steering committee some of the services and programs that are available in the community. So it's about all working together. You can see in the diagram there. Here in Saskatchewan, we had to start somewhere. So we developed a social prescribing advisory group made up of Dr. Dennis Kendall, Shan Landry, who was within the health system. Dr. Dennis Kendall, who is retired, was the head of the Canadian Medical Association as well as the Saskatchewan Medical Association for years. and we're tied in with that group is the Health Quality Council. So we have people who are in the field working from a medical or health point of view. So then we decided, where do we start? And we started with two pilot communities. The first one was Shaunavon. And the reason we looked at Shaunavon has an age-friendly community, where they pulled together a directory of services that were available within the community of Shaunavon, an area that might serve older adults. And we went in and we had I call it a discovery meeting, because we weren't saying you're going to have it here. It was going in and asking the community, would you like to be part of this process? So we had to look at an anchoring entity. And an anchoring entity is somebody who would hold on to the funding that we have to provide for the position of the community connectors. Some agency or council or whatever that has credibility to hold on to that money to be able to pay the community connector. Shaunavon Town Council, a young council, said, yep, we've got no problem there. We could do that, but we don't want to be overseeing the person or dealing with some of the things they may come up with. We need to keep the lights on and the water running in the community. And that's why we looked at a steering committee. The steering committee in the community was developed out of a meeting the same day we met with the town council, of people who have an interest in working with seniors, whether it be age friendly, whether it be home supports, whether it be home care, people from SHA, a whole bunch of different folks. We had probably about 27 people turned out to that. Of the 27, they brought it down to 4 or 5 people, because everybody said, we don't need, if we're going to make decisions, we don't need 27 people making decisions. Or no, nothing will get done. So they brought it down to a smaller group of people who will inform the larger group if there's are any issues. Once that was all decided, an agreement was signed with the anchoring entity in the community. The second one was Moose Jaw. Again, they had an age-friendly community. The anchoring entity wasn't the Moose Jaw City Council. It was the Moose Jaw and District Senior Citizens Association, again, a not-for-profit, but also had the credibility of being able to, they've got people working with them, they're paying people, they're getting grants from all federal and provincial. So they knew how to address money issues. And they developed their steering committee. That steering committee in Moose Jaw worked out really well. We had somebody from SHA on that steering committee. And they advised us to go and speak to one of the community physicians at one of the clinics, who turned out to be somebody who's from where I'm from in Britain, and we had a good chat. But the thing was, she was also the lead for the Saskatchewan Medical Association, not just the health authority, but the medical association for all family practice physicians in the province. So she made the connection with other physicians. She also said, I should talk to the emergency room physician in Moose Jaw. And we did, and found out that the person from SHA who was on the steering committee played rugby with this emergency room physician. So again, it was all about community, people knowing each other and working to the same end. So those were the two pilots. They've been up and running. They then once they got that together, put out postings for the community connector, and they have community connectors in place right now. So just to give you, I'm just repeating this here, and I won't spend too much time here. Here's what happened in Shaunavon, an area, and Moose Jaw area. And again, it's not just the individual community of Shaunavon or the individual community of Moose Jaw, because everybody outside those centres comes into those centres for services, be it doctors, be it clinics, be it hospital, all those types of things. So we had to look at the bigger area. So then, since that initial pilot process, we've added a number of others. The one we've added is Candle Lake, an area. It's the anchoring agency that is the resort village of Candle Lake, and the supervisory body is a local steering committee. People might think Candle Lake an area, and I did when I first started looking at this, but they approached us. Candle Lake isn't as small as you think. Around that lake, there are a number of communities. The area they cover in the medical centre covers Paddock Wood and Mead Park, edging on Prince Albert. We had looked at Prince Albert and spoken to the SHA directors and executive directors to see who it might be if they chose to do it in Prince Albert. And they knew that Candle Lake were really interested, and they are supporting Candle Lake. And while I was there at that discovery meeting with them, there was a gentleman sat beside me. He was asking me about this social prescription / referral form that would come from the medical profession over to the connector. And I wondered why I was always asking. It turns out he is the Deputy Chief Medical Officer for the north half of the province, Dr. Wingate. So again, I was happy because he got somebody that deep into the medical profession up in the north of the province there. So they came on very quickly. They now have a community connector. Just before Christmas, just after the municipal elections, I was asked to attend the first meeting of the new council. We put the proposal forward together with an individual by the name of Lisa Wilson, who works for the city on community. Some of you may know them. Carol, who's there from Sign, you may know Lisa, and also Andrew Sedley, who is the ED of Sign, was part of this process. So we made the presentation that evening. They actually said, yes, we would like to do this. And they've developed, or are still developing, this supervisory body, the Yorkton Area Social Prescribing Steering Committee. But again, they're in the process of, they've put a post out to try and get a community connector for that area. So that's where we're at right now. The next possible locations, there are two. One, we had started discussion with Rosetown and area, again, through their age-friendly community of Rosetown. But when they initially asked us in, it was just before the municipal elections. So they asked us to wait until after the elections. I'm going up there in 2 weeks' time to, I think, cement the initiative in Rosetown and area. And then the other area, I've got question marks there. Well, last Friday, we had a discovery meeting with the folks in Regina. About 50 people came to that first meeting. And already there are people, there's a bit of a buzz around, well, who might be the anchoring agency? Who's the steering committee? That's where we're at right now. So we've still got another 8 locations over the next 18 months, 2 years to bring on board. So that's what we're looking at. I could go on and talk more about it. I know NOFA has some documents there. There is a 2-page document which talks about what is social prescribing and how it works. The other one is a report that was done by KPMG here in Canada, who were with me in the UK in 2023 to see what they were doing. They've done a document which speaks to the social return on investment here in Canada by having social prescribing as part of the process. It typically shows for every dollar invested, there's a $4.36 return. So there is return on it by reducing hospital visits, reducing doctors' office visits, as well as falls and a number of other things. So again, there's some documents there. I've also put the link to the SSM, Saskatchewan Seniors Mechanism website, to the social prescribing page, because we had a virtual conference here in Saskatchewan in May last year over a 2-day period, and it speaks specifically to social prescribing, not only here but across the country. And we had Dr. Sam Everington, the little doctor I talked about out of London. He was the keynote speaker, and again, it might give you more information about things, how it could work. Will it work? Should it work? So I'll leave it there if there's questions, and there's my contact info, folks, if you need to get hold of me.